Good morning, everybody.
Good morning, Dr. Pat.
Good morning.
Oops. Okay. Hope everybody had a nice weekend. Let's go in here. Okay. So, as you know, we do a lot of downloads. All patients with pacemakers have remote monitoring. And this is an example of a download. So typically what will happen is when a patient does a download, it will do what they call a presenting electrogram, which is what we're looking at here in this teenager who is 10 years following congenital heart surgery and has a history of Mobitz 2 heart block, which I guess is the reason the patient has a pacemaker. And the question is, what do you think is going on here? What's happening? Why don't we ask Dr. Marshall what she thinks? Mommy, do I see you there? I think I see you there. Can you guys hear me okay?
Yeah, we can hear you.
Yeah. Maybe Molly's away from her.
No, sorry, my sound just kicked on. I didn't realize you'd called on me. Good morning.
Good morning.
So let me see here. Are the two lines like across the top at the same time?
Yes. So just for point of reference, we're seeing two electrograms. The top says A tip to A ring. So that's the atrial electrogram. And second electrogram says RV tip to ring, which are essentially the two poles of the bipole at the end of the lead.
Okay. So
The bottom is giving us the intervals between each of these electrograms in milliseconds.
oh, those are numbers between like the 180, 150. I see it. Okay. Okay. So the bottom, what it looks like is you have a little bit of an irregular or almost like a cluster at the bottom or on the RV strip of your ventricular rate. And then at the top, you're seeing the atrial signals, but as you're seeing that they're not in the same pattern, that they're not all conducting. And then you're having that this is 10 years after surgery with Mobitz 2 block pacemaker download. So
what's happening in the atrium and what's happening in the ventricle?
I mean, what looks like, I'm trying to see then how, since when, give me 1 second here. So on the atrial, because that atrial signal looks fast to me.
Uh-huh.
And
By the
so,
way, this is at 25 millimeters per second, as you can see on the upper right hand. So this is just like an ECG in terms of
yeah.
speed.
And so the atrial rate is very fast. At times it looks like less than a box. So at times it's a little irregular, but at times it's faster than 300. And then you're not seeing that on the V.
So what is the atrial rate roughly? When you
It's
say
very, I mean, it's variable, but it's around 300, at times a little bit
as fast as
faster.
300. Is it irregular or irregular?
It's a little bit irregular.
And is it regularly irregular or irregularly irregular?
I would say it's irregularly irregular.
Yeah, I would agree with
Yeah.
that. Irregular comment. Okay, so what do you think's going on?
And then you're seeing that correlate also in the V, as in you're not seeing a regular conduction of the V. So to me, this would be like atrial fibrillation that's not conducting, which tracks given the person has a history of Mobitz block.
Well, I mean, it's when people have AFib normally,
Does not conduct all of it anyway, but
right, yeah, if I put you in AFib, what do you think your ventricular rate would be? let's say you had the exact atrial rhythm that this person has. What would your ventricular rate be probably as a healthy young adult?
I would think around 100 or 150 like if you're having true RVR.
Probably would be in the closer to the 150s because you're a
Mhm.
healthy person. You have good AV node,
Mhm.
but it would not be 300, right?
No,
Could you
but this
think of a
person's is slower
circumstance?
though.
Say
But
that
you
again.
but my point is this person's ventricular rate, I guess the slowest is near 100, I guess. So I guess it's around 150. Sorry, go ahead.
I was just going to say, can you think of a circumstance where somebody might conduct faster than the
Yeah. So if somebody has evidence of WPW or accessory pathway that blocks their ability to block at the AV nodes, they can conduct faster.
right? So another way of saying that is it would just allow rapid conduction
Mhm.
potentially. Although again, remember, not all WPW pathways are slick and can conduct rapidly, but
Mhm.
certainly that would be at least a theoretical cause of fast conduction. But this is not fast conduction.
Mhm.
And presumably it's a combination of the fact that the atrial rate is so fast that there's a lot of what we call concealed conduction into the AV node, which blocks the node from the next beat as well, or even two
Mhm.
beats after. So, okay, so you're doing this download, and what do you think you should do about this? So this is just comes across, you're Jack Winters, you're the provider for the pacemaker clinic, and you're doing your routine downloads from the evening, and this is what you see. So what would you do first in this patient if this was your patient?
I'd first call them and check in and see how they're doing.
Okay. Patient says they feel fine. Not sure why you're waking them up at 7 a.m. Uh,
Um, and
this
then
was done just for, let's say, for the sake of this little story we're making. Let's say this was done on Saturday. And because, on the weekends, we don't check them unless the company, actually, we don't check them unless a patient calls us. So
so the
Saturday.
patient
So
called.
this is not uncommon, right? That Jack will come in on Monday because he checks it every day and he'll
Mhm.
see a download from 2 days ago after he left for the weekend. And
Mhm.
this is the tracing.
And then just to be clear, I'm guessing since we're going through this person's never had this before.
Well, that's an important question, right? You'd want to look in the records and see if this patient's ever been in this before. And the
Mhm.
answer to that question is no. This patient, to our knowledge, has never had this before.
Mhm. Uh, so I would call them and have them come in. And um they and you said it was from the weekend, so they've been like I would confirm that they're in it when they still come in, but
Is there any way that you could do that? Let's say they lived in Middletown, New York, which is an hour and a half away. Is there any way you could confirm they're still in it now?
they can do like a remote download, right?
Right. So they could do a repeat download.
Yeah. So I guess if they're not in it, then your acuity to things changes a little bit, but if they're in it, then would have them come in.
Right. Exactly. So, in reality, what happened in this case was Jack asked the patient to perform a new one, and
Mm-hmm.
in the new one, the patient was in sinus rhythm,
Got it.
uh, which was at least a day and a half after the time
Yeah.
of this download. So, so what would you then do about a patient like this? So you've never seen AFib in this patient before. Do you want to know anything else about this patient? Like, what are your concerns? Patient wasn't bothered by it.
Yeah.
So what are your concerns about this rhythm?
I mean, your concern with that rhythm is for like if they're in it for an extended period of time for thrombus formation.
Yeah,
Uh
sure. Why do
and
you think it is, Molly, that he doesn't know when he's in it?
because he has a pacemaker. I mean,
Well, let
well,
me
he's
ask
somebody
you
who has
this.
heart block anyway. I guess I don't know
Yeah.
what his baseline pacing is, but
Well, in this tracing, is he actually pacing?
no, not that, yeah, not at all. So I don't know what his baseline is like
So
when he
his baseline is that he conducts on his own about 85% of the time,
okay.
and
I mean,
rarely does not conduct. I
mhm,
remember this patient, and I think this was many years ago, and
mhm.
the pacemaker was put in because they were still having moments too, like 12 days after surgery. Every 12th beat was not conducting, and we were nervous about it. There were 1 or 2 pauses, so got a
Gotcha.
pacemaker.
So he's not feeling it. I mean, the rate itself is, again, like, as we've talked about, it's at a rate that isn't necessarily, I mean, it's a little tachycardic, but it's not, rapid conduction. So he may not appreciate that that's abnormal.
Yeah, that's a very, very important point you've just made, which is that most patients who are in AFib feel it when they have rapid conduction, but they don't necessarily feel it when they're not in rapid conduction.
Mhm.
And I can't tell you how many times we've had patients who come in with rapid conduction. Let's say it's not a WPW, but maybe they're going 140, 150. They don't like the way they feel. We give the patient a dose of diltiazem to block the AV node, and all of a sudden the ventricular rate is 92 instead of 152, and the patient will tell you that they are out of the arrhythmia.
Mhm.
And it's because the ventricular rate is what oftentimes makes people feel well or not well.
Yeah.
So you always have to keep that in mind, particularly when you're taking a history of somebody who comes in AFib, right? How long do we think it's safe to be in AFib before you will develop a thrombus on average?
I think of it as like, if you're less than 12 hours is more like considered to be on the safer end or like on the reassuring end of not. 12 to 24 to me, I think you're definitely at risk. And then anything like a day longer to me is definitely at risk.
So I think in general, most people would say, excuse me, 24 hours is usually the line in the sand. If we're confident that someone's been in AFib for less than 24 hours, we usually will feel comfortable to cardiovert without doing any imaging. But if it's more than 24 hours, then the risk of thrombus formation starts to rise quite significantly. You're right that, yeah, I'm sure that 12 to 24 is greater risk than less than 12, but as a general rule, I think the likelihood of an important thrombus is low if
Mhm.
it's less than 24 hours. And one of the important points I'm trying to make here is that when a patient tells you that they've only been in it for a few hours, you always have to, at least in your mind's eye, consider the possibility that they may have only felt it in the last 12
Right.
hours.
Yeah, I guess that's my thought of thinking between 12 and 24 is like if they're
Yeah.
not
I mean,
sure.
I'm always concerned about that because so many times, if you take a patient like this who does not feel it, but you ask them to climb 2 flights of stairs and raise their adrenergic tone, it's not uncommon that they will start feeling palpitations because they'll start conducting more rapidly, and they'll tell you that's
Mhm.
when it started or it started again, even though they've been in it all along. Turns out this patient actually is on warfarin for a
Oh,
mechanical valve.
okay. Or is others their patient?
So the risk of thrombus is not so high in this patient. So
Mhm.
okay, so you've done a repeat. The repeat shows that the patient is not in AFib anymore. So how would you go about monitoring this, you think?
I mean, you have the benefit of him having the pacemaker, so I don't like if you do frequent um downloads to see if
Yeah,
if this is something he's experiencing more frequently or again. Because it sounds
yeah,
like right now this is the first time that's happened.
yeah. You could do more frequent downloads. You could send him a Zeo patch, right, to see
Mhm.
just easily on surface electrocardiogram.
Yeah.
In this case, we decided to place, excuse me, a Zeo patch on this
Uh,
individual. And I believe it did not show, this was a while ago, it did not show any atrial arrhythmias. And since the patient is on warfarin anyways, the decision was made to just conservatively monitor this and see
mhm.
if this comes back. So,
For if this patient was somebody, because he has, I didn't get to ask, but and you mentioned he's on warfarin, but he has some type of structural heart disease. If he wasn't on the warfarin already, I guess my question is, would you like I don't know what his structural heart disease is and like how naturally predisposed, like how much he is at risk for atrial arrhythmias anyway, but I guess if he wasn't on that before, would you have still like watched to see if he had it again and then placed him on it, or knowing that he has structural heart disease and had an episode, start him on AC?
well, I mean, I think if he had risk factors for atrial fibrillation or thrombosis, I would. But
Uh-huh.
Um, assuming he was not on Coumadin already, if this was a first episode, if it terminated on its own, if we don't know how often he's having it, especially if it's this patient is completely normal intellectually, but if it was a patient in whom Coumadin or warfarin would be a challenging thing, one could argue to be as conservative as possible in terms of not starting it. One could even start Eliquis, right, which would be a little easier because there's not as many levels to monitor. Bunch of different options one could do, really, depending on the circumstance. So, but I think that this case really nicely demonstrates the value of remote monitoring for patients with pacemakers. This is something that in this patient, we would not have even expected this this was not even a diagnosis that this patient carried of atrial fibrillation. But now, unfortunately for them, the patient does have AFib. And so this is something that's going to need to be monitored and followed. And this, by the way, although it's unusual to have AFib as a teenager, we are increasingly learning how common AFib is in the adult congenital population. And I think that as these patients get older and older, this is going to become an epidemic of problems for the adult congenital patients. I think there's going to be a huge amount of AFib because of the hemodynamic burdens on the atria of chronic congenital heart disease, as well as surgical scarring related to the repairs. Of course, we could argue that the amount of atrial arrhythmia that we see is going to be lower than we would have expected without repair. That's certainly true, but I think that this is going to become a very, very serious problem in the future. Thankfully, our adult colleagues are getting better and better and better at doing AFib ablations and mapping complex atrial tachycardia. So I'm optimistic this will be relatively, will be treatable with a catheter-based solution over time. Okay, this is, since it's in one download, we'll do another one. This is another ACHD patient who has a congenital complete heart block. And this is the patient's routine download. And my question to you is everything okay with this? And why don't we go to Dr. Koloff? What do you think's going on here? And are we pleased with this? Part of the reason I'm showing this is I just want you to see what it is that we can see remotely, because this is one area of cardiology that you guys don't get as much exposure to because it's sort of happening in the background, but this is something you'll be involved with to some degree in managing your patients over time. So why don't we start with the presenting electrogram, which is the top right corner here. What do you think this rhythm is, Mohammed?
Hi, good morning, Dr. Pass.
How are you? So we have two electrograms, right? We have
yes,
again,
top
we have
tracing is the atrial and the lower one in the ventricles, right?
correct.
Looks to me like both of them are regular and it's one-to-one conduction.
Okay. I mean, is it conduction? Why don't you look at the marker? So in the marker channel on the bottom, it actually tells you what these electrograms are. So you see it says AS. What do you think that stands for?
Like sensing.
Right. And then it says VP. What do you think that stands for?
That's beat pacing.
Right. So what is the rhythm, you think?
So it's a sense beat paced.
Right. This is a sense V-pace rhythm because this patient has complete heart block. And does that look like a reasonable electrogram to you? I mean, does the rhythm look okay to you? Is that what you would expect for somebody who has congenital complete heart block who has a dual chamber pacemaker?
I mean, I assume so. It's just like there's some delay between the atrial and the ventricle.
Okay, but is that normal? I mean, somebody programmed this pacemaker. Can you tell on the program what the programmed AV delay is?
This is the 180 number, the base AV.
Yeah, so there's a paced and a sensed AV interval that the electrophysiologist can program. So this patient was programmed to have a PR or an AV delay of 150 milliseconds, which is, you know, fairly
It's
normal.
long.
Normal. Well, no, what's a normal PR? Up to how many
It's less than
milliseconds?
200.
Right. So if the person programmed it at 150 or 180, that seems pretty reasonable, right? It's pretty close to a physiologic AV time. We think that anything under 200 milliseconds should allow for a good amount of time for ventricular filling during ventricular diastole. Let me ask you this. Do you notice on the atrial electrogram, this is the A, right? Because you can see it says A sense. What is this? Why is there this little signal that follows every A, you think? So these are the A sensed. And you notice it isn't noticing anything here, but what is this little, there's this big signal which refers to, which is the atrial electrogram, but then there's this kind of little signal over here.
This was the intrinsic P wave. Um,
It's the what? Intrinsic P wave, you said?
yes. Okay.
No, that's not what that is.
Yeah.
Where do we, when we put a transvenous pacemaker in, when we put an atrial lead, what is the most common location that the electrophysiologist puts the atrial lead? Where does it usually sit?
Like on the right atrium.
Right, but where in the right atrium? Do we just find any spot that works, or is there one spot that's sort of the usual place?
I'm not entirely sure.
So the usual location is the right atrial appendage. In fact, the pacemaker leads come with a stylet that is curved, almost like an inverted U on the end, to allow the lead to retroflex up into the atrial appendage. So the most common location that, if we can, in an otherwise normal heart, we would normally put the atrial lead in the appendage. And the atrial appendage naturally lies sort of over the atrium, and the tip of the appendage can even be hanging over the RV outflow tract if you look at the outside surface of a heart. And so it's not uncommon that there is a little bit, whoops, sorry about that. It's not uncommon that there's a little far field ventricular electrogram on the atrial lead. So this is an A, and this is actually a small field V, which you see is sort of in time with the ventricular electrogram. Okay. So why don't we go through the information that we get on the download? So the first thing it says here is the remaining longevity. Is this a reasonable amount? Are we worried about this? It says 9.6 years.
I think it's reasonable.
That's very reasonable. That means that now these are not 100% accurate. You can't, you know, don't bet the horse on the, don't bet the whole house on this, but generally speaking, these estimates are you know, within a range of 6 months, I would say. So to have 9.6 years, excuse me, is a good sign that the battery is fresh and not a concern. So now we're looking at the lead impedances in the atrium and the ventricle, and it says that the atrial impedance is 1026 and the ventricular impedance is 418 ohms. So what do you think about those impedances, or what does the impedance generally tell us about the lead? Why do they give us this information? Why does it matter?
I'm thinking that the higher the number, the tells you how good in conducting the wire is, the lead is.
Well, sort of. It's essentially a sign of the lead integrity and the insulation. So if the impedance exceeds a certain level, it's a very common sign of a fracture of a lead or a problem with the insulation. Now, it's hard to know what normal is because every lead is a little different, but for these types of transvenous leads, I think up to about 1100 or 1200 ohms is considered okay. So about 400 to 11 or 1200 is the sort of standard range. One of the things we look at is not just the absolute value, but the trend over time. If you had someone who had a 400 ohm lead on the last check and now it's 900 ohms, that would give you pause and make you wonder or worry if there was a possible developing problem with the lead. This patient, interestingly, had a normal impedance at implant. The pacing impedance was like 500 ohms. And the follow-up one is 1,000 ohms. And to be honest with you, I wonder if I don't know why that is, but it has been a concern of mine in this patient, but it has remained stable at this level now for about 2 or 3 years. This device has been in for a couple of years now. So it seems like whatever the issue is, it's chronic and seems to be working okay. Also, this patient senses in the A 99% of the time because they have normal sinus node function, and so they're not really pacing, although the threshold is low. So capture threshold is off. What that means is that pacemakers have an ability, some devices, to actually measure the threshold beat to beat and adjust the output accordingly. That has been shown to reduce battery life, but that's mostly shown to work to reduce battery life when people are, as opposed to programming it as it comes out of the box at 3, which is 3.5 volts in 0.5 milliseconds. At this low of an output, as you're seeing here, 2 volts, I don't think there's much benefit to that, so I don't usually turn that on, but lots of people do turn it on. I should also mention that technology to assess the threshold for beat to beat has not been established to be effective or safe with epicardial leads, and I even am a co-author on a case report where we showed a case where if we had turned on capture management or capture threshold, that the patient would have not been paced or lost capture because of improper measurements for epicardial leads. All right, so now we have measured P wave and R wave. So it's saying that the atrial P wave is 6.9 millivolts and the ventricular is 6.9 millivolts. So what do you think about that, Mohammed? Are those reasonable P waves and R waves for the device to sense?
Uh, I think it's higher than.
So what do you think about 6.9 in the A? Is that a large atrial electrogram or a small, small atrial electrogram?
I think a large one.
Yeah, it's very large. Actually, if you look at the tracing of the presenting electrogram, it's telling you that every little box is 1 millivolt. So you can see that this is about 7 little boxes, which is why it's measuring 6.9 millivolts. So this is a very large atrial electrogram. For some reason, we got really good contact with the tissue, and we have a very, very, very good large P wave. And so the program sensitivity is 0.45 millivolts in the A. Does that sound reasonable to you?
Yes.
Yeah, I mean, if I program it at 0.45 and the P wave is 7, is it going to sense the A all the time?
So 6.10. Yes.
Yeah, it should, right? Because it's essentially asking it to sense a much smaller P wave than the actual measured P wave. Now, some might say that I could make it even less sensitive. I could have set it at 2, and it would still have a double threshold in terms of the sensitivity. The reason that we typically don't set it too low or make it too insensitive, even though the P wave is large, is just on the theory that in different positions, the P wave may change. And so even though in this particular snapshot that was obtained on this download, the P wave was 6.9, it might be 1.9 in another position. Especially the appendage moves a little bit with the patient's physical positioning. So we're just sort of being extra careful. What do you think about the R wave being 6.9? This is unusual in that the P wave and the R wave are exactly the same size. It's just a random finding, but what do you think about that? Is that an okay R wave?
I mean, yes, I think so.
Yeah, it's reasonable. I mean, generally speaking, we like the R wave is usually larger than the P wave, so this is a little bit of an unusual case in that they're the same size. And normally, and the reason for that is the ventricle is much thicker, has much more myocardium. So the signal you're recording off of the chamber should in theory have a larger R wave than the P wave is. And generally speaking, 4 millivolts is sort of our minimum acceptable R wave in most pacemakers or defibrillators. We would like it to be larger than that. We would like it in a perfect world to be greater than 10 or even greater than 20 millivolts. And why does it matter if we can sense the V, Mohammed?
We can sense it.
Yeah, why does it matter? Like in this case, right, the patient is A-sense V pacing. On every beat in this presenting electrogram, the patient's pacing the ventricle. So why does it matter if the lead can sense at all?
To keep the AV synchrony.
But it is AV synchronous while it's pacing, right? Where A-sense V pace, A-sense V pace, every one of them. Why does it matter that it can sense the V also? It clearly can capture easily.
Hmm.
Why does it matter if it can sense? What could happen if it paced, if it missensed, if it undersensed? What could happen? What if the R wave was 1 millivolt and I set the program sensitivity as is set here at 1.2? What could happen?
I mean, that can induce some kind of VFib.
Right. If if the patient had a PVC and the device did not sense it, the patient might get an inappropriate paced complex because it's not aware of what's happening in the ventricle, and you could have an R on T effect and have a real problem. So the lead must sense. And so even though this patient may be V-paced 99.7% of the time, you still want to know that it can sense in the rare event that the patient has their own intrinsic ventricular activity, such as a PVC. So, so in this case, so the bottom line is all of these numbers seem pretty good. This atrial impedance a little high, but not too high, and is very consistent with multiple prior downloads and office checks. Ventricular impedance has been stable, and all of these values are all stable, and we see A-sense V-pace rhythm. So this basically is a demonstration of a good download with no acute pacemaker problems and no acute patient problems, as opposed to this one where we found a serious patient problem. Okay, any questions about this case? All right, I think we'll stop here then. I hope everybody has a great day, and I'll see you at sign out in a little while. Thanks, guys.
Thanks, Dr. Pass.
Thank